to the ACR Journals on Air podcast. I'm your host, Vicky Shanmugam. Have you ever had the experience where you go to review the literature regarding a specific question you've had related to patient care, only to find there are several articles with published data about your exact question, but the data is completely conflicting? One of the things that attracted me to rheumatology when I was trying to decide on a specialty was that the role of rheumatologists is not just to follow protocols, but that it allowed for the nuances of the science to be incorporated into bedside patient care. In fact, as a junior doctor observing mentors around me, I loved watching senior physicians who had the mojo and who could use the literature to craft decisions tailored to their patients as people. COVID and the repercussions of the pandemic has created a lot of discord over conflicting opinions, and sometimes it helps to take a step back from conflict and look at the background and history of complex situations, so that we can understand why they have evolved the way they have. I've learned that approach can also help as we're evaluating conflicting data in science. We're going to review today an article published in ACR Open Rheumatology, Treatment of Multisystem Inflammatory Syndrome in Children, Understanding Differences in Results of Comparative Effectiveness Studies. And to discuss this manuscript, I'm joined by Dr. Mary Beth Sun, Associate Professor of Medicine at Harvard Medical School, Division Chief of Pediatric Rheumatology at Boston Children's Hospital, and senior author on the manuscript, as well as by Dr. Jonathan Hausman, Assistant Professor of Medicine and Pediatric and Adult Rheumatologist at Harvard Medical School and Boston Children's Hospital. John is also the host of our older sibling podcast, ACR On Air. Mary Beth and John, it's a pleasure to have you both on the show. Welcome.
Thank you so much for having me here.
Thanks, Vicky. It's great to be on this side of the table. Virtual table, I should say.
Exactly, because we are not only on the air, but literally in the air, in the clouds. So, okay, so just to get started, I wondered if you could help, and this question is really to Mary Beth, help us understand a little bit of the background of this study. So the manuscript is focused on the management of MIS-C, so multisystem inflammatory syndrome in children, which is a complication of severe SARS-CoV-2 infection, as we know, an ongoing problem worldwide. And it sounds like there has been some controversy based on conflicting studies from different cohorts regarding whether these kids should be managed with IVIG, steroids, both, either, neither. Mary Beth, can you give us some background to the study and tell us what the history of the controversy is?
Sure. So I think the struggle related to the rapid emergence of MIS-C back in the spring of 2020, we assumed that it was linked to SARS-CoV-2 in some way, but we really had no insight into either the pathogenesis or the treatment. And yet, despite that, we had critically ill children coming into our EDs. And so, at the front lines, we, clinicians had to make decisions. And so because there are features of MIS-C that look a lot like Kawasaki disease, which is one of the more common childhood vasculitides, there are shared features, clinical features, I should say, between MIS-C and KD. And so because the treatment for Kawasaki disease is IVIG, that was fairly rapidly implemented. It also has the reassuring feature that it's really quite safe. And so even if there were to be an infection at work, we really felt that IVIG was safe and potentially helpful. So we started with that. And then because we're rheumatologists and these kids were highly inflamed, we started turning to steroids as well. And so, of course, over time, we really wanted to study this, but there was really no opportunity for a randomized controlled trial given all of the challenges around the pandemic. And so we turned to observational data, 2 different cohorts, and we used statistical methodology, including propensity score analyses, to try to assess which treatments might be most effective despite limitations of those kinds of analyses. And so this goes back in July 2021, there were 2 paired studies published in the New England Journal looking at this specific question of, do you use IVIG alone to manage children with MIS-C as their first treatment, or do you consider using combination therapy of IVIG plus steroids? And so there was a large U.S. public health surveillance registry, which is called Overcoming COVID-19, that was actively doing surveillance in U.S. hospitals. And patients were being rapidly enrolled under this mechanism, and they had to meet the CDC MIS-C definition. And we divided those kids into those kids who got IVIG with steroids up front versus kids who just got IVIG alone as initial therapy.
Can I jump in and just ask a question there? Was that just based on clinicians making a decision at the bedside as to which therapy the kids were getting in that cohort?
Yes, we thought so, but we were a bit worried that the sicker kids were going to get steroids up front, and so part of the advantage of using propensity score analyses is that you can control for that. You can control for confounding by indication, meaning that sicker patients got more, and so we had enough kids enrolled in the cohort to be able to compare children with equivalent illness in the two treatment groups of IVIG versus IVIG plus steroids.
Got it.
And on the other hand, there's the BATS cohort, which stands for Best Available Treatment Study. This is a really impressively large international cohort that was enrolled a little bit differently. This was passive surveillance, and there's about 30% of the patients came from the UK, 10% from the US, and then 60% from other countries. And these children were enrolled two different ways. They could either be suspected cases of MIS-C, or they could meet the WHO case definition, which differs from the CDC in some important ways. And they also looked at these two treatment groups of IVIG plus steroids versus IVIG alone as primary therapy. And as it turns out, the results differed. So in the Overcoming COVID-19 study, the primary outcome there was cardiovascular dysfunction. So I feel like one of the key clinical features in these kids is that the reason why they're so ill is because they have hypotension and a shock-like appearance. And this can either be due to, distributive shock, or it can be due to the fact that their hearts aren't working well. So they have low left ventricular ejection fractions. And so we looked at that, and we found that if you gave IVIG plus steroids up front, that they really did have less cardiovascular dysfunction when you looked at them again at day 2 of hospitalization. Whereas the BATS cohort looked at that, and their outcome was different. They looked at either the need for vasopressors or ventilatory support or death at day 2. And they did not find that children who got IVIG plus steroids up front did any better than those who got IVIG.
And was that related to the fact that they weren't kind of focusing on this cardiac outcome, or that they weren't measuring certain things? Help us understand the differences between those cohorts.
Sure. So, fortunately, we had these, 2 studies with different results. And so, we just reached out to them. And there was this really, during the pandemic, there's so much isolation. But I felt like one of the really nice things about it is that there really was so much collaboration amongst physicians. And so we reached out to the BATS folks and decided to look at this more closely and figure out, were these answers different because the cohort itself was different because they used different definitions, or were the children sicker in overcoming COVID-19, and therefore detecting a difference in their response to treatment would be easier? And so we put that together, and that's the result is the paper that we're talking about today. And I would say that in the end, what we decided is that it really wasn't the case definitions based on looking at it very closely. It really appears that the overcoming COVID-19 cohort was in fact sicker. So specifically, they were more likely to be in the ICU, and they had more markers of cardiovascular dysfunction, including need for vasopressors, and more likely to be in shock, and then also to have higher levels of troponin and BNP. So in the end, we decided it wasn't a definition thing, it was an illness difference.
Yeah, interesting. Just to be sure I understand, these two cohorts were running around the same time. So it wasn't a variant-specific effect, right?
That's exactly right. Yeah, so we looked at similar time periods. That's exactly right. And so we were not comparing like a Delta cohort versus like an Omicron cohort or something like that. It was really all along the same time frame.
I'm intrigued by that, because is that the kids in the US were not... the OC19 cohort was predominantly US based, right?
Correct.
So were the kids in the US not presenting as early in the course of disease to the hospital?
Oh, that's a good question. There's a few potential reasons why the children were sicker based on these specific clinical measures that I mentioned. So one is that to know the background of the overcoming COVID-19 cohort. So this was a previously stood up group of PICUs, basically, of pediatric ICUs in the US that had studied flu together. And so most of the physicians involved were either ICU or ID. And so when that got converted over to studying COVID and MIS-C, it was the same network. And so it could be that these physicians who were enrolling just because of their job were seeing the sicker patients.
That makes sense. Whereas you think perhaps the BATS cohort that was 30% UK, 10% US, and then 60% other cohorts was more general pediatricians, or...
Right, it could have been, exactly, right. It could have been just a different kind of cohort. So we think that could be part of it, yes.
That would make sense. And I guess so part of the art of medicine, and I'm going to pitch this question to John as a pediatric rheumatologist and someone who crosses over from pediatrics to adolescents to adults. Part of the art of medicine is being able to integrate published literature into your own experience and expert opinion and use all of these different sources to guide treatment of the patients in front of you. Can you tell us what you're personally doing now for your own MIS-C patients, and how have you adapted your management over time as the data has evolved?
Yeah, so it has certainly changed. I was on service in April of 2020 when we were getting sometimes several MIS-C patients on the same day admitted to the hospital. And at that time, we were really throwing the kitchen sink. So anything that you wanted to give your patients, you would just do, whether it was steroids, IVIG, sometimes cytokine inhibitors. And, early on, we didn't really know what treatment was best. And then I remember coming back to being on service about 6 months later, and we admitted a kid with MIS-C. And my fellow said, okay, we should give steroids. I'm like, steroids? Why steroids? It's like, oh no, that's our guidelines now. There's been some data that suggests that steroids are, effective in helping patients with MIS-C. And so I've sort of experienced it firsthand in how this data, eventually trickles down to clinical care. And in the case of COVID and MIS-C, actually pretty rapidly. And I really have to thank Mary Beth because, within our hospital, Mary Beth and others within the rheumatology department have led the development of these algorithms that help us to better manage patients with MIS-C and other rheumatic conditions based on the best data available. So it's been a real change. Initially, there was no data and you could sort of do whatever. And now there's clear guidelines that have been established, at least within our hospital, that help us to better manage patients using the best available evidence.
And so, Mary Beth, as we sort of approach yet another wave of this horrible disease coming towards us, is your sense at this point that the IVIG plus glucocorticoids is becoming standard of care for these kids in the US?
That's a good question. I mean, I think so. I think from our point of view, I certainly feel more comfortable giving the combination therapy up front for the sick patients. I do want to say that just as you mentioned, Vicki, there is a real art to this, right? So even in the ACR guidelines for this, which there's now been like 3 iterations, they do say that steroids could be held if there's a contraindication for that specific child, right? So I think then the question comes up, like, if the child wasn't as ill, so specifically not in the ICU, not requiring vasopressors, could you instead give IVIG plus maybe a biologic? I mean, I still think that there's enough to be learned that is a reasonable thing to consider for the individual patient who's sitting in front of you. But I would say, like, at least from my point of view, it's been really nice to have actual data to work with for like the majority of the sick patients to sort of know best how to treat them and how to get them better quickly, because they really can be critically ill when they hit the door, and it's a little frightening for both families, patients, and providers. And so I think we certainly use that here, that combination therapy up front for any child who looks ill.
Yeah, I certainly, can, as you were talking, remembering back to my junior faculty days when we did used to, as adult rheumatologists, cover the pediatric floor at the hospitals, remember that feeling of sort of heart in your mouth feeling of the decision-making for somebody's child with these incredibly complex diseases is really quite nerve-wracking. And so I think it is helpful that this data is getting disseminated quickly and that people are having at least a meaningful dialogue about what the differences and the variations in how studies are done and how that means that the data should be interpreted. I think it is quite helpful. Are these cohorts both still ongoing? And so are we going to get continued data with the new variants as time goes by?
That's a good question. I do think that there'll be further data from bats, actually. They at least had indicated that in their first publication, that they were looking at it more closely to see if, in fact, having larger cohorts sort of bore out the same finding, or if perhaps the combination therapy might look a little bit better. From an overcoming COVID-19 point of view, there are still analyses going on. And just as you mentioned earlier, Vicki, I think there's a lot of interest in knowing is there a difference in these cohorts across variants, right? So in terms of like severity of illness or presentation of illness. And so I do think that there'll be forthcoming work. I think the idea of a randomized trial is a little bit hard, although there are people hard at work at that as well, which is wonderful and important because we should always try to get data from that when possible. It's just the pandemic made that, very tricky.
Yeah, one of the things that I've seen is, the number of patients coming in with MIS-C has dropped dramatically. Initially we were, as I mentioned before, we were getting, several patients sometimes per day and certainly several per week. And last time I was on service, we only had one. Mary Beth, have you seen that as well? And do you have data on how maybe Omicron, there may be a decreased risk of MIS-C among these patients?
Yeah, so it's a really good question. I would say, so here in Boston, where John and I work, there was a really significant peak of COVID-19 cases. Certainly in January, there was an enormous peak. And we did have a fair number of MIS-C cases after that. But with this recent peak in May, that was in the middle of May. It's now the middle of July. So we are now pretty much outside the window for MIS-C presentation. And we did not have a large influx of MIS-C cases the way we had consistently with the prior peaks of COVID-19 cases. And so the question is, well, what's going on there? I don't think it can be strictly attributed to vaccination because vaccination uptake in kids has not been, so it's obviously been staggered across the different age groups, but even with that, I don't think the numbers are as high as we want. So I don't think we can just say that it's because of vaccination that we're seeing fewer MIS-C cases. Although just to throw it out there are data to say that vaccination does protect you against MIS-C specifically, which is great. So I don't know why we haven't had as big of a wave. And is it because it's, Omicron BA4? Or, you know what I mean? I'm not sure that we really have all the answers there. I think there's probably something really to be learned there by people who are much smarter in the lab looking at all this. But we have not seen the big peak that we were all sort of bracing ourselves for over the spring.
That's great news. And I guess as a parent, I will just keep my fingers crossed that trend continues because goodness knows it's certainly a terrible disease. So thanks, John and Mary Beth, for putting this data in some context. And I'm going to change topics now just for the last couple minutes. You may have heard in a previous podcast, I am doing a lightning round with some of our guests so that listeners can find out a little bit more about you as people and what drives you. So I am going to ask you a few lightning round questions. Are you both ready?
We're ready.
Okay, so what is your favorite book? And John, I'm going to let you pick a podcast that has changed you either as pediatrician, rheumatologist, and question first to you, Mary Beth.
So in my free time, I tend not to read anything related to medicine, just to give my brain a little bit of a break. So I recently reread a group of short stories by Jhumpa Lahiri called Interpretive Maladies. And I just find that reading books outside of my experience hopefully make me a better physician.
Yeah, well, so the people who specialize in understanding burnout would certainly tell you that that's true. And I think it does help us think about the world differently. So, John, what about you? You can pick a book or a podcast.
Yeah, so certainly the most books I read are children's books, which are sometimes a lot of fun. In terms of podcasts, one podcast that I really enjoy, it's called The Knowledge Project with Shane Parrish. And he basically interviews, people that are sort of at the top of their game and helps us to understand like what's behind them, what drives them, what challenges they face and how they overcome some of those challenges. And I've really learned a lot from that podcast.
Love it. I'm going to look it up. Great tip. Thank you. And then to both of you, tell us about a rheumatologist or a mentor who inspired you. And Mary Beth, go first.
I would say as a rheumatologist would have to be Rob Sundell, who is the epitome of the clinician educator to me, who, provides amazing care to his patients and his families while educating the rest of us around him.
Perfect. And John?
So I happen to agree with Mary Beth. It's got to be Rob Sundell. I remember 20 years ago, it must have been over 20 years ago, I was working as a Spanish interpreter at Boston Children's. And I remember that I was helping to translate the interactions between patients and their families. And we had one I had the fortune of working with Rob Sundell in translating, and I remember the care that he took with his patients in examining the nails and the nail bed capillaries. And I was just so struck by how detailed he was with his patients and thorough that first I wanted to become a doctor. And then once I was in my residency program, he was sort of the epitome of a doctor's doctor who, anybody in the hospital, if they have a problem, they would ask Rob Sundell to see what he would do, because he always had these very clever insights. So certainly Rob Sundell is a big reason why I'm a rheumatologist today.
That's amazing. And you truly saw him in action before you were even a physician, then, it sounds like, which is kind of a great mentorship story. He probably didn't even know he was mentoring you.
Yeah, that's right.
So both of you are accomplished academics, educators, and clinicians, but we all know there are only so many hours in the day. And you also know, as people who care for children, that it's important for all of us to learn how to set boundaries. So how do you personally and professionally decide what to say yes to, or more importantly, what to say no to? And Mary Beth, I'll let you take the first.
Yeah, really excellent question for everyone and for working parents. So I would say as I've gotten older and taken on more, I really try to say no to things that I think that I either won't enjoy or won't learn from. I mean, I don't think you enjoy everything about your job, but I think we're lucky to be physicians. And I think that I try hard to pick the things that I care about. I mean, that's across the spectrum, like, admin, research, clinical care, all of it. But I try to say no to things that I just don't think I'm going to care about.
Yeah, good tip. I think that actually is a good boundary to have. If you know it's not going to bring joy, then don't take it on. There are other people who it probably would bring joy to. How about you, John?
I struggle with that every day. I mean, just yesterday I was leaving clinic. It was like 5:15 in the afternoon, and the 4:00 patient showed up. And, where are my boundaries? Do I see them? Do I not see them? I ended up seeing them because, they had so many issues to deal with that it was certainly the right thing to do. But, that also made me late for dinner with my family. I think establishing, I'm still working on it. I think it's a work in progress. You mentioned before books. I think one book that has really been impactful, at least in terms of setting boundaries, it's called 4,000 Weeks, Time Management for Mortals. And it's really not a book. It's really not like a time management book. It's more of a book that says that we will always have too many things to do, too many emails to reply. And basically, you're never going to get anything done. And the point of it is you just have to be okay with that. And I'm slowly getting to be okay with that, having a full inbox and having, tons of things to do and tons of things for which I have no time for. So hopefully I'll get better at establishing boundaries, but I think it's still a work in progress for me.
It's like medicine. It's practice and art, and your life changes over time and you need to adapt, I think, is what I've learned. John and Mary Beth, I want to thank you both for joining us today and for sharing your insights. It's been a pleasure having you both on the show. Thanks for coming.
Thank you so much.
Yeah, this was wonderful. Thank you.
So I'm going to close this episode just by saying thank you to pediatric rheumatologists all around the world who, like our children, teach us so much. They push the boundaries of research. They're willing to jump in with 2 feet, but they keep asking why, just like my children. And it was nice to hear today how even the pediatricians need to set boundaries. Thank you, everyone, for listening. ACR On Air Journals Edition is a production of the American College of Rheumatology. Please rate and subscribe to our podcast at acronair.org or wherever you get your podcasts.